Spending on cancer care has more than doubled in the past decade and is projected to reach nearly $175 billion by the year 2020. That's a concern for any efforts to try to control healthcare spending. The question is, how can you control cancer spending without harming patients? It starts by looking to see where spending on cancer care goes. Average spending on a patient receiving chemotherapy is over $45,000. But very small amount of that cancer spending actually goes to the oncology practice. The fees that an oncology practice receives total less than 10% of the total spending on cancer patients during an episode of chemotherapy patient. 90% of the money pays for drugs, for laboratory tests, imaging studies, surgical procedures, emergency room visits, and hospitalizations. So where are the opportunities to reduce spending without harming patients? First of all, a lot of those emergency department visits and hospital admissions occur for chemotherapy-related complications, and either the complications can be prevented or the patient may not need to go to the hospital if they could get care from the oncology practice. Many of the tests that patients receive and many of the drugs that they receive are either unnecessarily expensive or unnecessary altogether, and there's a lot of unnecessary treatment that occurs near a patient's end of life. There's significant savings possible by reducing these areas of avoidable spending. For example, projects around the country that have received the kinds of resources they need to provide better care for patients have actually been able to reduce total emergency room use and total hospital admissions by over 50%. A number of studies have shown that some of the most expensive drugs used during chemotherapy treatment are used inappropriately or unnecessarily and could be avoided. And a significant proportion of cancer spending occurs for hospitalizations and treatments shortly before a patient dies. The problem is that the way we pay for cancer care today doesn't really support appropriate treatment for patients. There is no payment made for the significant amount of physician time that's spent outside of face-to-face visits with patients determining an appropriate diagnosis and treatment. There is no payment for the time that patients spend with non-physician staff such as nurses, social workers, financial counselors in terms of determining what is an appropriate treatment and how to manage their cancer care. And oncology practices do not get paid for the kinds of services that would help patients stay out of the hospital for complications. There's no payment to support 24/7 response to patients whenever they have complications, and there's no payment for having extended hours or open schedule slots for urgent response to needs. In fact, studies have shown that the payments that oncology practices receive only cover about 2/3 of the costs that they incur for the services that they provide to patients. The balance comes from the margins that oncology practices have to generate by purchasing drugs and by providing other kinds of testing services in the practice. So the failure to pay for good care actually leads to a lot of the costly low-value services that patients receive. And obviously, providing better care could avoid some of those unnecessary and inappropriate expenses. So the first goal of payment reform for cancer care is to pay for the kinds of care management services that would prevent the emergency room visits and hospital admissions. That could save money and offset the cost of paying for those additional services. The second goal is to pay for the kinds of services that are needed to make sure that patients are receiving high-value treatment. We don't have to guess about what those changes are. The American Society of Clinical Oncology has issued Choosing Wisely guidelines identifying a number of different areas where drugs, testing, and other things could be reduced without harming patients. So that would achieve savings and offset the cost of those additional services. The gap between payment and costs is not just in total amount, but in the time period in which the payments are made. There is a significant mismatch between what practices receive payments for and how they incur their costs. For example, before treatment even begins, oncology practices provide a significant range of services, everything from determining the appropriate diagnosis, identifying available treatment options, discussing those treatment options with the patient, coordinating care with other physicians, providing a wide range of counseling for the patients. But the only thing that is paid for is face-to-face visits with physicians in the office. There is no payment for all the services delivered by nurses, social workers, financial counselors, and there is no payment for the time that physicians spend on phone calls with patients and other physicians, researching treatment options, etc. When a patient is receiving oral chemotherapy, there is a wide range of services that the practice must provide to make sure that the patient is getting the appropriate drug and can deal with situations in which they may miss a dose or have complications. But the only thing the practices are paid for are face-to-face visits with physicians. There are significantly additional payments made if a patient is receiving infused or injected chemotherapy, but that payment is linked to the drugs. It does not cover all the other services that the patient may need in terms of having response to complications, participating in a clinical trial, and all of the other kinds of services that a practice provides. And if a practice wants to provide care management services or rapid response to complications, there is no payment to support those costs. And after therapy ends, patients' needs don't end. In fact, practices provide a significant amount of services after therapy ends, developing a survivorship or an end-of-life plan, continuing to monitor for recurrence of cancer, responding to complications that may arise after treatment ends, helping patients manage pain. All of those services are very important to patients, but the only thing that practices are paid for are face-to-face visits with physicians. So instead of this current mismatch between payments and services, a third goal of payment reform is to align the payments that oncology practices receive with how services are actually delivered. So the American Society of Clinical Oncology has developed a better way to pay for cancer care called Patient-Centered Oncology Payment, or PCOP. How would this improve the payment system? Well, if you start with the current fee-for-service structure, the evaluation and management service payments for office visits and the infusions for infused drugs, the first thing that PCOP would do is add a significant new payment during that crucial diagnosis and treatment planning stage, $750 one-time payment for each new patient. Second, PCOP would add a $200 per month care management payment to provide flexible resources to the practice to help patients deal with complications and provide other kinds of services during their treatment. There would also be a smaller care management payment after treatment ends and during months in between when treatments are given, because patients still need services following the end of treatment to help them with some of those post-treatment issues and to be able to deal with complications that may arise after treatment ends. And finally, PCOP would propose a monthly payment for patients on unfunded clinical trials to support the research that oncology needs to do to determine which therapies are most effective and to determine how to adjust those therapies based on different patient needs. In total, these payments are expected to average about $2,100 per patient. That would be about a 50% increase compared to what practices are receiving in fee-for-service payments today. An obvious question is, how can we afford to increase payments to oncology practices by 50% when we're trying to reduce the cost of cancer treatment? Well, if you recall, the payments that oncology practices receive represent 10% of the total spending that occurs while a patient is receiving chemotherapy. So a 50% increase in the payments to the oncology practice would only represent less than a 5% increase in the total spending on cancer care. And if the oncology practice can reduce the spending on drugs and tests by 5 to 7%, and if it can reduce the number of emergency room visits and hospital admissions by 30%, that would generate a more than 4% reduction in total spending, more than paying for the increase in payments to the oncology practices. And as I've noted earlier, the Choosing Wisely list that ASCO has developed identifies a wide range of these unnecessary tests and treatments. And studies have shown that variation in the use of these different kinds of tests and treatments leads to a significant increase in spending in many practices. So reducing that spending would be able to offset the increased payments to the practices and generate net savings for payers. The document that American Society of Clinical Oncology has produced about PCOP shows the calculations how you can achieve net savings by paying practices better and having them focus on the areas where spending reductions can occur without harming patients. This is a simple system for payers and practices to implement because it simply involves 4 new billing codes. An oncology practice would bill a payer for a new patient treatment planning for each patient who comes into the practice and begins treatment. They would bill monthly for care management during treatment and during the active monitoring period after treatment ends, and they would bill for patients who are in clinical trials. And they would continue to bill for all of the existing fee-for-service payments that they receive today. So PCOP is actually a win-win-win for patients, payers, and practices. The oncology practice would receive higher payments than today, which would enable them to provide better services to patients. They would focus on the specific areas where spending can be reduced without harming patients, avoiding the use of emergency rooms and hospitals for complications of treatment, and following oncology guidelines for the use of chemotherapy, supportive drugs, testing and imaging, and end-of-life care. And that would reduce spending overall for payers. Now, how does PCOP compare to other payment reforms that have been proposed? Well, there's really three criteria that you have to use to evaluate payment reforms. The first is, do they provide significant and predictable resources to support high-value oncology care? Second is, do those payments match the costs that oncology practices occur by the phase of care and the type of care they're providing? And third is, are those payments tied to appropriate use of drugs and tests, not to savings per se? So if you compare what many payers have been doing, quality pay for performance programs that provide more money if practices demonstrate performance on quality measures meets one of those criteria. But in general, quality P4P programs do not provide the kind of resources that practices need to be able to support high-value oncology care. A number of payers have been implementing shared savings programs, and PCOP is a much better approach than shared savings programs for a number of reasons. Under a shared savings payment model, oncology practices generally only receive higher payment for improved care management if they can already show that they can reduce spending, which raises the question, of course, as to how can they reduce spending if they haven't been able to improve services. In contrast, PCOP actually provides the payment up front in return for the practice agreeing to deliver high-value patient care services. There is no guarantee of any savings for patients or purchasers under shared savings payment models, whereas under PCOP, practices would be required to focus on using guidelines for treatments and testing and for reducing preventable emergency room visits and hospitalizations, which would assure savings for purchasers. Under shared savings payment models, practices that are already practicing efficiently and effectively may receive little or no revenue and may even be forced out of business because they've already been saving money for purchasers. Under PCOP, a practice that's already efficient receives the payments that they need to continue delivering that high-quality, affordable care. Under a shared savings model, practices that have been practicing inefficiently or inappropriately would be given additional payments and more than the practices that have been practicing efficiently, whereas under PCOP, the practices that have been practicing inefficiently would still be paid more, but they would be expected to generate significant savings for payers by following appropriate use criteria and reducing hospitalizations. Under shared savings payment models, practices could be rewarded for denying needed care as well as reducing overuse because they would receive a share of any savings that they generate. Under PCOP, patients are protected because any savings that are generated because the practice is delivering appropriate care. And finally, under shared savings payment models, practices are placed at risk for costs that they can't control and for random variation in spending. Under PCOP, practices are only accountable for services and costs that they can control. So the shared savings payment model actually does not meet any of the criteria for a good payment reform in oncology. The Medicare Innovation Center has announced a payment reform called the Oncology Care Model that is designed to improve payment for oncology practices. So how does it compare to these goals for payment reform? Well, one has to determine first, how does it actually change the payment system? So if you look at that structure that we talked about before in terms of the mismatch between payments and costs, what the oncology care model does, first of all, is it provides more payment during the treatment period, which is when practices are already receiving the largest amount of payment. Under the oncology care model, the practice would receive a $960 new payment, 6 monthly payments of $160 for 6 months after a chemotherapy treatment is given. In addition, if the practice can reduce the total spending on healthcare services to their patients by more than 4%, they will receive the savings back as a bonus payment from Medicare. Now, the question is, where will those savings come from? Will they only come by reducing avoidable spending? If a practice has avoidable spending it can reduce, that could potentially generate significant savings. But a practice that has already been able to reduce avoidable spending would thereby not be able to have as many savings opportunities and would not be able to receive the kinds of bonuses that other practices would receive. Medicare, and a question becomes, would a practice actually withhold expensive but necessary care in order to be able to generate a bonus payment? Medicare has proposed a number of quality measures that a practice would have to meet, but it's really impossible to generate enough quality measures to be able to ensure that practices aren't stinting on appropriate care for patients. In addition, under the oncology care model, a practice receives payments for a fixed 6-month episode. So once a chemotherapy treatment is given, an episode is started and it continues for 6 months regardless of how long treatment actually takes. So if a treatment only takes 3 months, the practice still gets a 6-month payment. Now, many people understand that during chemotherapy treatment, patients may have to delay treatments because of side effects, etc. So what happens if a patient is supposed to be getting a 6-month treatment regimen and it takes 7 months to be able to deliver that treatment? Well, logic would say that it's now simply a longer episode, a 7-month episode rather than 6 months, because it took 7 months to deliver the same treatment. But under the oncology care model, Medicare says that's a totally new episode and the patient receives another $960 payment for another 6-month episode. Moreover, the shared savings payments are based on spending during an episode. So if you have 2 6-month episodes instead of 1, you're far more likely to be able to generate savings, or at least phantom savings, and be able to receive a payment from that. So that raises the question about whether practices that are successful in helping their patients avoid side effects are going to be penalized financially, and whether there is actually an incentive generated for practices to stretch out treatment. So it's good that the oncology care model is providing extra payment for practices. But what's bad about the oncology care model is that it could encourage delaying treatments in order to increase payments to the practices. It could encourage stinting on care in order to achieve shared savings. It puts the oncology practice in the position of being accountable for all spending on their patients, even for health problems unrelated to cancer. The target spending level used to determine savings is based on historical spending for the practices on patients, so practices that are currently overusing drugs and treatments and managing patient care poorly get rewarded more than practices that are being efficient and effective. And the methodology for actually making sure that the spending targets are adjusted appropriately so that practices aren't penalized whenever new drugs are developed or there is new evidence about the effectiveness of treatments, that has not yet been defined. So it's not clear how well it will work. So the oncology care model meets one of the criteria. It provides significant and predictable resources for high-value oncology care, but it doesn't match payments to costs, and it doesn't tie payment to appropriate use rather than savings per se. Other payers have been implementing a variety of programs. For example, United Healthcare has had what they refer to as an episode of care payment program. And it does tie payment to appropriate use rather than savings per se, but it doesn't actually provide an increase in resources for practices or better match the payments to the costs that practices incur by the phase and type of care. The payer that has come closest to meeting these criteria is Anthem and its Cancer Care Quality Program, which provides significant and predictable resources for high-value oncology care, and it ties those payments to appropriate use rather than savings. But it still focuses the payment during the treatment process and doesn't provide the kind of resources needed before treatment begins and after treatment ends. The only payment model that actually meets all of these three criteria is the patient-centered oncology payment. Now, the basic PCOP model that American Society of Clinical Oncology developed improves but does not replace the current fee-for-service structure. It adds on 4 additional payments on top of the existing fee-for-service structure. But the existing fee-for-service structure is a very complex structure. So An option that was developed as part of the patient-centered oncology payment structure is to be able to consolidate both the existing fee-for-service payments and the new payments into a much simpler structure. So there would simply be a one-time new patient payment, and there would be a single monthly payment for each month in which the patient is getting treatment. Now, those treatment month payments would be adjusted based on the acuity of the patient and the toxicity of the treatment that they're receiving, but it wouldn't be based simply on how many infusions the patient received or how many office visits they made. And then there would be active monitoring month payments. So in each month after treatment ends, the practice would receive a payment for each patient, and that payment would be reduced over time as the patient's needs reduced. This would dramatically simplify the whole coding and billing process that exists today. Today, oncology practices are paid with over 50 different billing codes for patient visits and for infusions. Under the patient-centered oncology payments consolidated payment option, this would be reduced to fewer than 10 new codes. This would provide simpler, more flexible payment. So rather than paying for all those existing fee-for-service codes, there would simply be a new patient payment, treatment month payments, and monitoring month payments. And the practice would still be accountable for ensuring appropriate use of drugs, testing, and end-of-life services, and for providing the care management needed to be able to avoid hospitalizations and emergency room visits. And a second option would provide virtual budgets for oncology care. So rather than paying separately for all the other services, practices would receive a bundled monthly budget to cover the costs of drugs, emergency room visits, testing, etc. And then they would have the flexibility to be able to redesign care completely for better outcomes for patients. In all of these options, there would be quality measures, particularly those focused on avoiding underuse. So quality of treatment planning for a new patient, quality of care during treatment, quality of care following completion of treatment, and then the payments to the practices would be adjusted based on how well they performed on those quality measures. These payment options also provide a transition path to the future. So the basic patient-centered oncology payment model with the additional fee-for-service codes could be a first step. Then a practice could transition to the more bundled payments to the practice. And then they could transition to these virtual budgets for oncology care where they're managing the overall costs of treatment. To implement this, purchasers and payers who are partners with practices are needed because oncology practices can't change the way they deliver care unless payers agree to pay them differently. Oncology practices can't even estimate the potential savings from these kinds of changes without receiving data from payers on utilization and prices today. And there is uncertainty on both sides. Oncology practices will wonder whether they can meet performance targets, and payers will wonder whether the savings will offset the higher payments. So a true partnership is needed to create a win-win-win approach. If you want to learn more about the patient-centered oncology payment model and how it compares to other payment systems, this report from the Center for Healthcare Quality and Payment Reform called A Better Way to Pay for Cancer Care is available, and it can be downloaded free of charge at www.cancerpayment.org. And there is much more detail on the patient-centered oncology payment model available from the American Society of Clinical Oncology at their website, www.asco.org/paymentreform.